Hi, it's Georgie, and this is Fempower Health Audio Insights, where I break down the biggest issues in women's health so you can navigate the system with confidence. Whether you're a patient, policymaker, or provider, these insights give you the power to make informed decisions. And today's piece is about something that 150 million women around the globe use, and that is IUDs. One common thing women will say when they are getting the IUD inserted is, "It felt like I was being stabbed." And this pain can no longer be ignored. In fact, the American College of Obstetricians and Gynecologists issued new guidance that aligns with last year's guidance from the CDC. But the question is, what will happen in clinical practice? Before we dive in, I first wanted to say thank you so much for tuning in, because by tuning in, it shows me that you value your health and the health of the women in your life. And if you think this is something that they need to be aware of, please share this episode. And if you would like to continue having the Fempower Health podcast feed in your podcast feed, please subscribe or follow the podcast on Apple and Spotify, because that will ensure that this content reaches the women who need it most, and their loved ones, of course. So let's dive into this topic. Quotes that I've often heard based on Reddit threads, TikTok videos, and others are the following. "I screamed in pain during my IUD insertion. No one told me it could be that bad." Or another one, "They said I'd feel a pinch. I couldn't drive myself home afterward." Another one is, "I asked if I could have anything for the pain, and they said it wasn't necessary." So for years, patients have described these intense, unmedicated pain during in-office gynecologic procedures like IUD insertions, only to be told it's quick, routine, or nothing to worry about. But now, as I mentioned, two major health authorities, ACOG, which is American College of Obstetricians and Gynecologists, and the Centers for Disease Control and Prevention, the CDC, have now said what patients have known all along. Yes, these products can hurt, and no, pain should not be ignored. But acknowledging pain is just the first step. Whether anything changes in the exam room depends on more than guidelines. It depends on a combination of factors, including clinician awareness of updated guidelines and willingness to adapt, clinician capacity given the demand for their time, especially with the rise of OBGYN shortages, patient experiences with already long wait times and short appointments, the reimbursement rates for pain alleviation, and effective patient or self-advocacy. Let's talk about these new guidelines. In May 2025, ACOG released the Clinical Consensus on Pain Management for In-Office Uterine and Cervical Procedures. You like that formality? And then in August 2024, the CDC updated its U.S. Selected Practice Recommendations, or the SPR, on IUD placement and bleeding management. Okay, so that's fancy formal, so you know that it's real, okay? So let's dive in. So together, they send a clear message. Here they are. So one is, lidocaine should be offered, and this comes in two formats. So there's paracervical blocks, so that's a lidocaine injection near the cervix. Another is topical lidocaine, which can come in the form of a spray or cream. Both are recognized as effective pain relief for IUD placement and similar procedures. Misoprostol, I think that's how you pronounce it, misoprostol, is not recommended for routine use. So despite past use, the guidelines suggest it causes more side effects than benefits unless you've had prior failed IUD insertion or have cervical stenosis. The other is, their guideline says patients must be counseled. ACOG urges providers to use trauma-informed, culturally competent, and shared decision-making approaches to pain management, tailoring their care to each patient. While this is important, with 10-minute doctor appointments and what doctors are trained on, I am not quite sure how much trauma-informed, culturally competent, shared decision-making approaches they have learned in med school. And this is not at all a knock on doctors, not a knock on med schools, because it's a complicated healthcare system. But I really appreciate this guideline. I'm struggling with the reality of how that will work. Again, this is why self-advocacy is so critical and why I'm telling you about all this stuff. So some of it may sound scientific, but you need to know this, because if you are getting an IUD, you may have to advocate for yourself. And I'm not kidding you. Print out the guidelines and bring them to the doctor if you need to. All right, if these are the guidelines, why are patients still in pain? So this is where reimbursement enters the picture and often derails the care patients deserve, again, outside of these short 10-minute appointments. Insurance doesn't always pay for pain relief. Many in-office procedures are coded and billed as quote-unquote simple, leaving little room for add-ons. So paracervical blocking billing may not always be reimbursed separately. Sedation or anesthesia is often only covered in hospital or surgical settings. So if you're interested to read more about this, I actually have a link in the blog post version of this episode, and you can read more about that. There's also pre-procedure counseling time, but that's rarely reimbursed adequately. And this is really important to take into account, because pre-procedure counseling time presumes the doctor has all that extra time is going to get properly reimbursed for that, which doesn't necessarily happen. So even when clinicians want to do better, they may not be able to offer what's recommended, not because they don't believe you, but because the system won't support it. So something I've said is there are guidelines, and then there's lived experience, and then there's reimbursement. So what happens in the exam room is where these collide. So what does this reveal about women's health? Well, this is why patients, whether it relates to IUDs, pelvic pain, or other factors, often feel gaslit, not because their clinicians are necessarily heartless, but because 1, the workflow doesn't allow for personalized care, and 2, the billing structure rewards speed, not support. This gap between what's ideal and what's real is where so much harm happens. I always like to end with a solution. So what can you do as a patient? If you're preparing for an IUD insertion, biopsy, or hysteroscopy, 1, print or link to the guidelines. Bring the ACOG and CDC documents and frame it as a collaboration, not a confrontation. And again, you can check out the link to the blog post version of this in the show notes, and I'll have links to the documents there as well. The other is use specific language. Be succinct and clear with your clinician. Speak the language they can understand. For example, you can say, I saw that ACOG now recommends offering lidocaine. Can we talk about what pain relief options you offer? So I want to say something here that's really important. I was meeting with a friend of mine, and I mentioned to her that another friend who does market research in healthcare, they did observations of clinician-doctor interactions. And I think they called it the FINE study, because they wanted to count how many times the patient would say, I'm fine, when the doctor would ask them questions. And so if we go to the doctor and they want to help us and all we say is, I'm fine, it's not going to help. And what's interesting is we may do it more than we think, because this friend of mine said one of her doctors read the notes from a different doctor that this friend attended, and her doctor said, I think we need to go the next layer down, because the amount of times when your doctor is trying to ask you information and you respond, that's fine, because I spend more time with you as your therapist. I know the next layer down, and you need to share that next layer down with your doctor. So I did want to share that, because this is really, really, really important. So really look at yourself and say, am I giving my doctor specific language? Okay, so just something we can't stop iterating. The next is ask about coverage. So if your clinician can't offer a paracervical block or sedation, ask, is this because insurance won't cover it, or are there other limitations in this setting? And be sure to ask about this with the billing department prior to your appointment. You don't want any surprises, and they probably don't either. And the next is, don't be afraid to reschedule. It's okay to say, I'd rather come back when pain relief options are available. You deserve a plan, not panic. But again, this can be alleviated if you ask about the coverage before you go to the doctor appointment, because some of them may still charge you that cancellation fee, and you don't want to have that. So let's give credit where credit's due. ACOG's acknowledgement of systemic racism, trauma, and the historic dismissal of women's pain is commendable. It's rare to see a clinical body name these truths, but guidelines alone don't guarantee change regardless of whether we are talking about IUD insertion or another topic, unless insurance companies, health systems, and providers commit to implementation. Patients will continue to suffer needlessly. So a final thought here. Reddit posts from patients blindsided by IUD pain still exist. Patients continue to hear it only lasts a few seconds, but now you have something to point to, guidelines by both the CDC and ACOG, and hopefully one day soon, the table won't be where pain is dismissed, but where it is prevented. I hope you found this episode helpful. Again, check out the show notes for all relevant links, and please do follow this podcast if you would like to hear the voiceovers of my blog posts, and also check out all the interviews I've done with leading experts for the past 5 years. Additionally, feel free to sign up for the weekly newsletter where I explain all of these dynamics in our healthcare system so that you can have a better experience. Thank you again so much for tuning in, and please share with any friends who would find this information helpful. Thank you for joining me today on Fempower Health. If you'd like to continue the conversation, please follow me on social media. I am most active on Instagram, LinkedIn, as well as TikTok. You can also subscribe to the weekly newsletter if you want to stay off social media to get the latest and greatest updates. And you can find the link to that either on my website, fempower-health.com, which is a hub to all the different health topics I've covered over the past 5 years, or you can go to the show notes where there's links to all the helpful resources that are relevant to this discussion. And if you know of someone in your life who would benefit from this information, please do pass this along, because that is how we can ensure this important information reaches those who need it most. And for anything that is discussed medically, please understand that none of what we share on Fempower Health is medical advice. It is all for information purposes only, and only a conversation between you and your doctor can give you the care that you need. Thank you very much.